and it looks like it's a day 4. So we'll just kind of walk through it and see what we got.
So let's do a quick just review of how we're going to heal, okay, the 3 phases. There's the inflammation phase, that's where we are right now, okay? Then there's the repair phase and there's the remodel phase. Remember, the main 4 negatives of through the healing phase is the scar tissue and the repair phase. It has these 4 negatives. If it heals wrong, there's increased nerve sensitivity, there's an increased number of nerves that get trapped in that scar tissue. It always feels less strong and less mobile. Okay? The therapies and the adjustments helps us heal right so we don't have these. Okay. All right. Let's go to switch categories down to the test. Okay.
Okay, so that was pretty good. So this is a day 4. And the first thing we do after the introduction and all that is we do a quick reminder of the 3 phases of healing. And that was good. So it was real simple. He just covered the 3 phases. And then he covered the most important part, which was the 4 negative aspects of healing and how it could cause a problem. And of course, that's what the goal of the therapy is. And it was nice and quick. So that was good.
Here. So when you first came in, you were at 8 out of 10. Okay, obviously, that should be a 0. Didn't have pain for healthy function there. Tenderness, right when I pushed on that lower lumbar spine, that L5 area, more on the left side, you were at a 10. You even said 11 on the exam. So that's pretty tender. That doesn't need to be there. That should be a 0. Nerve test, I know, again, you were feeling it down to your...
So remember, we need to get them to talk. We can't just... Now, for the initial introduction of the 3 phases healing, it's not interactive, which was fine. But now when we're going through each of the findings, we got to check them off. One of the worst things you could do in communication is to cover multiple topics and not engage the person you're talking to. It's one of the worst things you could do in communication. So we need to make sure we're engaging that person. And I would have, in this particular case, I'd have said, now, when you first came in, you said you were having low back on a scale of tone 1 to 10. It was whatever the number was. Scale of 1 to 10, it was a 4. Is that right? That's what that would have sounded like. Is that right? In other words, I want to engage them. And remember, you want to engage people real early on, not at the end, real early on. Why? Because it grabs their attention. It makes them pay attention.
Your left knee, but you did pass all the nerve tests clinically. Like, I didn't detect anything clinically from feeling and strength necessarily off, so that's good. You had 2 positive joint tests. One was the straight.
Yeah, just so you know, patients don't know what that word means clinically. I wouldn't even use it. I mean, you know the difference between clinical and administrative. They don't. Just say the category, whether it's the test, orthopedic test, nerve test, whatever. They don't know what clinically means specifically. That's what's called an industrial word. The concept industrial word means you and your colleagues know what that means, but it's the people that you deal with, whether it's your patients or your customers, depending on what field you're in, would not. That's called industrial language. That's what that's called. Never use industrial language talking to patients. Why? It creates paradigm shifts, and paradigm shifts decrease trust, decrease confidence, increase defenses, and increase resistance. Never use industrial language with your patients.
Running the leg straight up, which represents disc pressure. And then another one we call Kemp's, where I twist you and I bend you back. Those are positive. So we want to get those better as well. Those should be there. Range of motion, okay? When you flex forward, like you bent forward, and that was your primary restriction, right? At work, when you bent forward, you were at a 10 out of 10. So that was an 8. And then when you went back in extension, that was at a 10. Those should be better than a 0. Muscle strength was fine, nothing there at all. Okay, now let's go to...
Again, we're not hearing any engagement. So after that, I would have said, does that make sense? Does that make sense? That's what I'd have said. But we're not hearing him at all. We're just kind of barreling through this, which is not good. Because remember, we want to engage them to see if they're with us and take them along But what's the main reason? The main reason is to look for obstacles either verbally or visually. Verbally or visually. So there's many reasons why we engage. You know, the positive reasons are is to make sure that you micro step people so there's no big paradigm shift when you get to the end. But that's not the number one reason. Number one reason is you're looking for problems. You're looking for them not being with you, for them not agreeing with you, for them being confused. You're looking for because it's the problems that are going to stop the relationship. Now, what's interesting about this, when you're in a state of conscious competence, in other words, you got to kind of think about what you're doing while you're doing it. Usually you don't have the ability to engage or evaluate the other person because you're too busy thinking about what you have to say next. That changes in a state of unconscious competence. That's when you'll just know what to say, like muscle memory. And that's when you'll really be able to pay attention to what they're saying or not saying, their body language, their facial expressions, their reactions to what you're saying. That is the highest form of communication, is when you can evaluate the verbal and nonverbal clues of who you're talking to while you're talking. Now, one other point I'd like to point out here to make this simpler, we've got to make this simpler to the patient. And so remember I said, however many major bowel markers you use, like in the example we use, it's 8 major categories of bowel markers. It could be 9. If you did blood tests, it could be 9. Maybe you had a special technique, you know, that it was a specific bowel marker, 10, whatever, okay? Maybe you're using another type of diagnostic tool, whatever but generally speaking, it's 8. So remember, you want to use that. You want to package it and use it because it makes it easier to correlate and understand. In other words, what's happening right now is there's no big picture overview. That's what's happening right now. We're just going from one to the next, to the next, to the next, to the next. It's harder to understand, as opposed to, let's say you had 8 bowel marker categories. You said, now, then you say there's 8 specific categories of tests. Now, remember, we don't use the word bowel markers with patients. We call them tests. So my point is, it's much easier from a communication standpoint to say, now remember, there's 8 specific tests that will determine if you're getting better, worse, staying the same, or if you'll end up with a permanent injury. See, I compartmentalized them. I said there were 8. Then you go through and you go, number 1, this is where you were, this is what it should be. Number 2, and by the way, that's how you say it, number 1. Number 2, okay, because it's easier to understand when you bullet or put numbers to things. And obviously, you not only want to be saying it, you want to be showing it. You want to do everything you can to show, because of the 55% of communication is visual and only 7% are the words. So while I'm showing them the records, whether it's on a computer, whether it's paper, whatever your setup is, but make it simpler. How do you make it simpler? Say there's 8, package it, create a package. It's 8, okay? Makes it so much easier. And that's how it would be said. So now remember, there's 8 specific categories that determine how well. And remember, those categories, what do those categories do? They told us the diagnosis. They tell us whether you're getting better, worse, staying the same, or if you end up with a permanent injury to some degree. Now, I would write down what I just said. I would literally, because that's what you need to be saying all the time relative to the test and patients. Well, Mary, remember there's 8 specific tests that tell us not only the diagnosis, what the problem is, but tell us whether you're getting better or worse, staying the same, or if you eventually end up having a permanent problem to some degree. I would just write that down, write it down, learn it, say it. That has to be unbelievably reinforced. Third-party findings. Third-party findings is what patient education is about. And then simplify it, package it. Say there's 8. Then when you go through the 8, say this is 1, this is 2, this is 3. And what it would sound like is this is 1. We checked your range of motion, whatever 1 is. So let's say, let me go in order. So typically 1 is symptoms. Say number 1 is your symptoms. Obviously, when you're healthy, you'd have no symptoms. On a scale of 1 to 10, you were a 6. That's not good. Next is tenderness. Tenderness is from inflammation. You shouldn't have any tenderness or inflammation if you were healthy. We tested you. We grade that 0 through 3. Yours was a 2. That's not good. Next is we tested the nerves. That should for your reflexes and sensation. That was good. So that's a very good sign. Number 4, we checked your orthopedic tests, your joint test. Those all should be normal. The main one for you is that when we press down, this is called Kemp's test. When we press down on that, it was painful and tender. That should be normal. Now that's not good. It's not only not good, but that's one of the most important tests for your problem. We need to pay a lot of attention to this test. This is what it sounds like. It's very specific. See, I'm saying number 1, this is you, this is normal. And then did you notice how I commented on it? That I said it's not good, it's good, this should be normal, and it's not. You have to tell them, you have to interpret it for them. They don't know this. They don't know it. Okay. So that increases the communication. It increases the effectiveness of your communication when you do that. So package the 8. However many you're going to use, start saying there are 8 specific tests. There are 9 specific tests. There's whatever, however many you're using. Start packaging it. Start saying it. There are 8 specific tests that tell us not only the diagnosis, what the problem is, that tell us whether you're getting better, worse, staying the same, or if eventually you end up with a permanent problem to some degree. So number 1, that's how it sounds. Unbelievably simple. Unbelievably simple. It makes it simple is what it does. When you don't do that, like what's happening now, you're just jumping from one to the next to the next. It's a little more of a run-on. It's harder to package. Okay, so you always want to package things. Packaging makes things easier. Packaging meaning, bulleting or numbering them. It makes understanding things easier. And by the way, it's very easy at the end when I say, so out of the 8 tests, 3 of them were normal, 5 of them were abnormal. That's not good. Well, it's very easy for somebody to understand 5 out of 3 were normal and abnormal. See, that's what they'll understand that. Here's what and they'll remember that. Here's what they won't remember. You have a positive Kemp's test. They won't remember that. That's meaningless. But they will remember 5 out of the 3 were positive, and that's not normal and it's not good. They will remember that. Simplify it, package it, and simplify it.
Okay. Let me just show you a normal one so I can show you what I'm looking for. You guys see this?
Okay, so I don't know what happened here, but we didn't cover all the basic tests. So let me just give you a quick reminder. Remember, what are all the categories of the basic tests? Day 1, it's tenderness, symptoms is always first. Tenderness is second. Nerve tests are third. Joint tests are fourth. So those are the tests on day 1. Cover them in order. Get used to always covering them in order. Remember, when you do things repetitively, don't change them. It's easier to remember. If I heard ABC, 3 days in a row, it's easier to remember ABC. Okay. So, so that's the first 4. Typically in day 2, you're dealing with muscle strength. Let's see, got muscle strength, or excuse me, range of motion, muscle strength, and then you have any disc degeneration, and then x-rays. Those are the typical 4 biomarkers on day 2. So those are your 8 typical biomarkers. And that's why I had x-ray last. See, right now we should be covering them in order. The order that we educated the patient on. Don't change the order. Don't educate the patient in one order and then change it when you talk to them about it later. Stay consistent. It helps for retention and understanding. So get those 8 down, stay in order, and say the most important statement you can say in patient education, which is these tests are going to determine. They not only told us the diagnosis, they tell us whether you're getting better, worse, staying the same, or if you end up with a permanent injury to some degree. And I said to some degree to soften permanent injury. That's the single most important statement you're going to say in patient education. Because now it's third party. It has nothing to do with you. It has everything to do with the test. Okay, so let's see where we're at here.
Back. This is the front. This would be the person like standing with me that way. Maybe notice the curve. See these 2 bones here? Notice where, if I were to draw a line, see how they will continue to circle? Okay, look at these 2 bones. That's the thing I want you to notice. With that one, in comparison to yours, okay? You see how this line, if I were to draw a line, would be kind of a circle line. You see this, guys, okay? You see this bone here? This is the bone I'm pushing on when you're laying face down. This one and this one, see how it's pushed this way? Yeah. See how if I drew a line, it would actually have to go this way. These 2 bones are your problem areas. They're pushed back. Okay, they need to be pushed forward. And also, they're stuck. They're not mobile. Okay, you see that? X-rays don't show you motion. It's just a static picture.
Okay, the motion should have been talked about in your ranges of motion. Okay, but remember, when we show x-rays, we shouldn't have to try to talk somebody into an x-ray. And chiropractors routinely try to talk people into an x-ray. It's not what should be happening. So what should have happened is you show the normal x-ray first and you put significant emphasis on what you're going to show him on his x-ray. Now he did that. But what did he not do? When he went to the normal x-ray, he immediately told him what it was. Don't do that. Why? You don't know where they stand. You don't know if they can see it. Don't do that. Don't tell them what's on their x-ray. What should have happened is when you flip the switch on for their x-ray or put it up, you should have said, can you see it? Can you see the problem? That's what you should have said. And then you shut up and you look at the patient and you look at their face. And then you're going to interpret if they understand if they understand and can see the problem. So if they look at it and they with assertion say, oh yeah, that's definitely decreased or something. Click, I'm done. Yep, that's exactly the problem right there. Click, I'm done. They go, you go, can you see the problem? And they go, and they're squinting. They're kind of bending forward and they're squinting a little bit and they're pausing. What does that tell you? It tells you they don't see it. Okay? So do not tell the patient the problem before you ask them to tell you if they see the problem. Because you're going to interpret not only if they see it or not, but how they tell you will tell you to a degree how important they see it. I mean, I'll have patients look at an x-ray and go, oh my God, is that it right there? Is that mine? Well, just by the tone and the words, what did that tell me about how important, not only did they see the problem, but how much they understand it's a problem? See? Because of the tone and the words, how they said the words, not exactly the words. Okay? But that's how, show them the normal x-ray, be unbelievably specific with what they're going to see on theirs. Either put their x-ray up now or flip the switch, however it is you do it. Shut up, ask them, do you see the problem? And the very next thing you say after they say it, let's say they do say it, say, what is it that you, tell me what you see. That's the second thing I'll typically ask them if they didn't. If they just said, yeah, I see it, and they didn't tell me, then I'll say, what is it that you see? I want to make sure that we're talking about the same thing, okay? Now, as soon as they say the problem and see it, click, I'm done. Off, I'm done. That's how fast. It's over. I'm not going to try to talk him into anything else. The only goal is to get him to see the problem. That's it. You're done.
So that's why it's just one test. That's why we got to prepare the range of motion and everything like that. Okay. You know, I would put you at phase 1. You see how over time the disc gets thinner? Okay. These 4 negatives, again, one of the primary.
Okay, now that was a hell of a jump. We went from x-rays to spinal degeneration, and he didn't even talk anything about spinal degeneration. He just went in there and said, oh, you're phase 2. He didn't introduce spinal degeneration at all. There's 5 stages of spinal degeneration and how your spine degenerates. And right here is where it looks like you're at. You're whatever. I mean, you don't just throw them in the middle of it.
So the mop analogy, the scarfish going wrong, again, that's the primary precursor of arthritis. Okay, that's what we're going to try to prevent that. This case, okay, once we lose it, we can't.
You shouldn't be telling them this. Now, let me tell you. If this was an associate doctor in my office, and I'm in there, at this particular point, I'm stopping him. I'm interrupting him right now. Why? Because he's talking him into the x-ray, which chiropractors commonly do. I don't care if my associate can see the damn problem. What do I care about? I care about if the patient can see the problem. What's the only way we're going to know that? By shutting up and asking them. Right now, I would literally step up and go, Mr. Jones, can you see the problem on your x-ray? I'd be interrupting him right now. And one of the reasons I'd be interrupting him, and he would know it as soon as I interrupted him, to know that he's doing it wrong, to get him to know, shut up. You shouldn't be talking right now. You should be asking him to see what he sees.
All right. So, options, I always tell patients we have 2 policies of time and money. The first policy of time is usually you don't wait longer than 5 hours.
Now, take the word tell patients. Take that out of your vocabulary. Tell. Nobody likes to be told anything. Take that word out of your vocabulary. So how should that have sounded? You should have just said we have 2 office policies. You shouldn't have said we tell patients. And by the way, we don't care about other patients. We have 2 office policies. We only care about him. He doesn't care about any other patients. He only cares about him. Don't ever talk about other patients. You're only talking to him. That's the only person he cares about. So just say we have 2 office policies. Now, but he missed it though. Remember, you always finish with x-rays with 2 statements. So we got a problem with this x-ray here. What should have happened, besides what I've already covered with the x-rays, is he should have covered, does that look normal to you? That's one question. And if it stays like that, do you think the problem is going to go away, or do you think it's always going to come back? We got to get the patient to see it, get him to say it's not normal, and get him to say it's going to come back if it stays that way. That's what you got to get him to say. Okay? So those two questions were not asked. Okay? Now, why do we have to do that? What do we buy? We buy things that are not normal, not okay. That's why you're doing it. That's what we buy. You're getting him to say it's not normal and it's not okay. That's what we buy. That's why you're getting him to say it. We don't buy things that are okay. So that's what should have happened first. Then we should have just went right to that. There's 2 office policies.
Usually you're going to have to go within 115 open. Monday through Thursday, 9 to 6, and then Friday, 9 to 9. Our office policy on Monday, you try to break it off into terms for patients that work for you. Sometimes it's only $27 every week. With that being said, again,
Okay, we didn't hear him. So you made 2 statements. There was no engagement. We didn't hear him. Nothing. We got nothing. I mean, I really don't like how we're not hearing much at all from this patient. This is not good. You're going to lose patients. It's the number way to know whether you're the patient's with you or not, and you will lose patients by not engaging them as you cover every category. So when you covered the 2 obstacles, one is time. What would I have said? I'd have said, and you're probably aware of that, aren't you, Mr. Jones? The few times you've been here, you see that we get you in pretty quickly, right? That's what I would have said. I'd have just reinforced the time that he's already experienced, that he should have experienced anyway. Number 2, when I covered the money part, I'd have said something like, does that sound fair? That's what I said. Does that sound fair? But you got to get them involved.
back to the 3 phases of healing, where do you want me to get your bow back to? Okay, you want to get back to here, is that right? Okay. So how long we heal depends on 2 factors, our age and how long.
See, and that's when you do everything right, that's kind of what happens, just like that. It says, how long do you, which of the phases do you want us to help you get back to normal or as much as possible? And I think he said all of them or something like that. And then he confirmed it. But that's pretty much what happens. Any normal person would want everything to be normal. It's just common sense. So when you delivered everything properly up to this point, that's what you should get. If you don't, you can be guaranteed it's because of a subtle money or time issue, and on occasion, a trust issue. That's the only reason a normal person wouldn't want to be normal.
This one takes anywhere from 6 to 12 weeks. Okay, and this one I usually see the person around 3 times a week. This one is more around 9 to 20 to 25 visits. Okay, this though is more like we're breaking care out. It's more strengthening, remember, because the tissue's so weaker.
Okay, you're moving too fast. You're moving too fast. You got to keep the categories linear in their separate columns. So first cover time, then cover visits. Don't cluster them. You start clustering different categories, what happens? It creates confusion. Don't mix categories. Cover time first. So that's why we would have said in your case, this can take there's a low end and a high end based on age and how long you've had the problem. In your particular case, we're probably looking more at like 8 weeks or whatever it is, 6 weeks, 8 weeks, 10 weeks, whatever it is. Okay. All right.
Well, this phase again, I'm going to put you on the lower end. If I put you at 6 weeks, 3 times a week, that's if I put you on the lower end here, that's okay. So 18 plus 9 is 27. Okay. Now on the 12th visit, we're going to.
Yeah, just remind them when you cover that section, like the repair phase, Remember, what is the goal of the repair phase? Remember, you should remind them what is the therapeutic goal of each of the three phases. So remember, the goal of the inflammation phase is to decrease pain and inflammation of muscle spasms. Now, the goal in the repair phase, in other words, that's what we're talking about right now, remind us, tell them it's to increase your active, passive, and joint motion without pain or discomfort. That's the goal of the therapy. Then when I come over to the remodel phase, I'll list out the visits. I go now, and I'll typically say the goal first. The goal of the repair remodel phase is to increase strength and elasticity to decrease the likelihood of re-injury or a permanent injury. Tell them what the therapeutic goal is. Tell them the time frame, then the visits in that category. Let me say it again. Tell the goal of the category first, the time that you suggest, then the visits for that category. Be very clear, be very distinct and separate. Then go to the remodel phase. Tell them the goal of the therapeutic goal of the remodel phase. Tell them the time frame of the remodel phase. Tell them the visits for the remodel phase. See, now it makes sense. Now we're not just talking visits and time. There's actually a reason behind visits and time.
Reeval. We go over the evaluation of the 12 visits to see where we're at. Again, that's the beauty of the test. They tell us if we're doing better, same, or worse. Does that make sense?
And that's important to throw everything back on the test. Every 12 visits, we redo the test. And that's when you should say the statement again. And remember, those tests not only told us what the problem is, but they're going to tell us whether you're getting better, worse, or the same, or if you're going to end up with a permanent injury to some degree. Everything depends on these tests. That's what it would have sounded like. Reinforce that.
But at 27 visits, that's what it's going to take initially to get us from here to just through there. Okay. And not only do we feel better, but also it doesn't come back. Let's get our pulse now, okay?
Okay, so that was good. Then he did a transition statement, said, okay, let's cover cost. That's very good. You're letting them know we changed subjects.
At 27 visits, okay, there's a $47 copay for again, that will cover everything you would also do, like when you re-exams or whatever. The payment option, we give you a 20% discount. So 20% off of that, $250 for one option is just get a 20% discount when you just break it up into two. The third one is the term. So this will all take give or take 8 weeks.
Okay, now you started with, you said one option is we break it into 2 payments. Okay. And remember I said, when I'm training, I do not have any of my doctors do ask for all the money up front at all. Why? There's a real big human reason. It's very easy to have your confidence destroyed when you ask for it all up front and they go no. I've seen it. I'm telling you, I've seen it. I mean, I personally have experienced it. And then what happens is a lot of doctors stop asking for prepays altogether. It totally destroys their confidence. So when would I allow a doctor that I'm training to ask for all the money up front, or he did an abbreviated version and he asked for 2 payments? So it was a modification of all the money up front. When would I allow my associate doctors to do that? Only after their prepay rate was over 50%. They were already getting over 50% of the people to prepay. Then I would allow them to say one option, which there's 2 payments. That's it. Okay. But you can destroy somebody's confidence unbelievably fast when they're rejected with payment.
6 months. So if you pay every other week, like bi-monthly, bi-weekly, you pay every 2 weeks. It comes to 12 payments. So 12 divided by 1,015 comes to
See, and I missed the logic here. Oh, wow. 6 minutes and 15 seconds into this, and I just heard another person in the room. Are you kidding me? Are you kidding me? And it sounded like a woman, meaning his wife. Are you kidding me? He's been sitting there the whole time, and we haven't heard the co-decision maker and the potential new patient? Are you kidding me? All right, what's the rule? What's the rule when there's somebody else in the room? First of all, who's the decision maker? We got a man there, we got a woman. 87% of the time, the woman writes the check. So if I don't even know anything about their personalities, I better damn well pay a lot of attention to her. Those women are the ones that'll nix you. The only person that the woman won't nix is the alpha male or the high collar. That's the only person that spouse will not nix. They'll be able to control it. In other words, you got a 50% chance of getting nixed right now because you did not engage the decision maker. Okay, so what's the rule when there's another person in the room? So we got another patient, sounds like it's his, or I'm going to make the assumption it's his wife. What's the rule? 60 to 70% of the time, you should have been talking to her, not him. You already knew him. He already knew you. You've already been together 3 other times. This is the 4th time you're together. And by the way, this is a very, very, very common mistake. Why did he pay so much attention to the patient? He's comfortable with the patient. He spent this is the 4th day spending with the patient. That's why. He's not comfortable with the other person. I see this all the time. Huge mistake. 60 to 70% of the conversation should have been the other person. Why? Because you don't have any relationship with that other person. You don't have 3 days that you have with your patient, number one. And remember, when there's somebody else sitting in that room, we're talking to them for 2 reasons. One, to see if they're co-decision makers, so they say, yeah, go ahead and do it. 2, we're going to get them as a new patient. That's what's going to happen. But it's not going to happen with what just happened. This is exactly what not to do when another patient's in the room. 60% of the time. And then as you went through each category, you should have checked off each person individually with most of the emphasis on the spouse because she's never heard anything. This is all new to her. My God. Huge mistake here with a spouse in the room. So, all right, remember, when the spouse is in the room, 60 to 70% of the time is talking to them and then reaffirming and then checking off them that they understand it and agree, and then checking off your patient. And I just go back and forth with each category. That's how it works. In other words, it would have sounded like this when I started. Let's say her name is Mary, and let's say the patient's name is John. I say, now, Mary, when John first came in here, he said he was having low back pain on a scale of 1 to 10. 10 being worse, he said he was a 7. Were you aware of that, Mary? Okay. John, does that sound right? You said you were 7, right? Okay. Number 2, John shouldn't have any tenderness, Mary. When you're normal and healthy, you have no inflammation and tenderness. Now, John did. He had a scale of 0 to 3. His was a 2. That's not good. Now, John, again, you should have no tenderness, and yours was a 2. And that should be a 0. Next one is the nerve test. Now, Mary, we checked his reflexes and his sensation. They were good, Mary. We don't have to worry about that. So that's a very good sign. John, you remember that? We checked your sensation, nerve, reflex. That was good. So that's very good. Next one was the orthopedic test. We checked the joint test. And now this, for John's problem, this is one of the most important tests to pay attention to. And that test, it was a compression test on the right. It was positive. What it means there's joint pressure. Does that make sense, John? Okay. The 5th test was, see, that's what it would have sounded like. The attention would have been on Mary, secondary the patient. And I would have checked them both off as I took them through. That's what it should have sounded like.
I get paid every 2 weeks. Okay, and then we do it on Monday too, so we can start this on Monday.
Okay, so, but I'm a little confused here. Let's go back to payments. So one option that he said there's, you get a discount, there's 2 payments. The other option is a payment every 2 weeks. Well, what advantage is it to anybody if, to pay every 2 weeks versus, or excuse me, 2 payments versus every 2 weeks? The answer is none. There's no motive. So why would you do it? You shouldn't. There has to be a motive. If you're going to ask for all the money up front, I mean, think about it. How much sense does it make to go, well, you get 20% off if you pay it up front, you get 20% off if you make 2 payments out of it, or you get 20% off if you pay it every 2 weeks over 4 months. Well, what the hell you think you're going to pick? There's no motive to pay for it up front.
Well, I can't do Mondays because where I work at, we're short-handed on Mondays. I'm getting like 4 people.
Okay, so now they agreed to the payment, or he's going to time, started on Monday, and the guy's saying no. So does that mean we're going to just bail out? No, we're going to fight through time. We're going to remind him of the 3 time factors that we can get him in and out of here. We're not going to quit on time. Let's see what happens.
Okay, I can't do Mondays.
He can do any other day. Scott just told him he can't.
I don't care. So she's jumping in saying he can't do it either. I don't care. I'm not quitting on time. I'm going back in there with my 3 major obstacles and I'm clearing them out. And I have over 50% chance Monday's going to work for him. Don't quit on time here.
I'm talking about the payment.
Oh, that was wrong. That was confusing to me too. You confused them and me. You're talking about the payment. That payment shouldn't have started Monday. There's no way in hell that payment should have started Monday. That payment started today. I don't know what you're thinking. Do you go buy under the store and they let you just walk out of there without paying anything? Is that how the merchandise works? No, we want them to make a commitment now. Why would we put off a commitment? One of the things that increases your commitment the most, which is paying money. Why would we increase the obstacle of time, which decreases the likelihood of them participating? Remember that concept, time kills all deals, motivation decreases every 48 hours, 50%. Remember that? And you just threw in 24, 48, or 72 hours to help block them from paying. Why the hell would you do that? No, they're paying today.
Yeah, we just, because we have a lot of patients, so if we do it every day, we would be confused. So we just do it on Monday. The payment is on Monday.
All right, we got to talk about that. That's screwed up right there. You don't delay people's payment because you got a lot of patients paying. I don't know what the hell's going on there, but that's totally wrong. People pay right now, so they're committed right now. It's about them getting committed. If you got inefficiencies because of people paying, you got a big damn problem, because people paying is the most important thing you got to get. Shit.
Yeah.
Imagine Walmart letting everybody walk in and walk out and say, okay, you can start paying on your stuff on Monday. Guess how many of them would start paying?
Treatment-wise, I would want you in 3 times a week to start. What days work for you there?
Okay. We just jumped categories again. So there was confusion. They were thinking treatment. He came back to money. There was no agreement on money, I don't think I heard. And now he's going back to treatment. So we're mixing categories again. You got to stick with one category and nail it down. I don't think, let me go back and listen. This money thing was not nailed down.
So we just do it.
And what kind of confusion can we have with money? Absolutely nothing. Let's see what happens here.
on Monday. The payment will come in on Monday. Yes, sir. Yeah, treatment wise, I would want you.
Okay, so yeah, he did get the agreement for Monday. Okay. But no way in hell we're waiting for payment down the road. You're making the first payment now. Damn it.
In 3 times a week to start. Okay, so what days work for you there?
No, that's not how it sounds either. What days work for you? Well, guess what happens when you ask patients open-ended questions? You get assertive, definitive answers when you ask patients open-ended questions. Hell no, you get shit. Never, I mean, we don't ask that kind of shit. You tell them. You're the doctor. You tell them. We're going to see you 3 times a week, Monday, Wednesday, Friday. Then you're going to go in and fight the obstacle, their false perceptions of time. And you're going to nail the damn thing. We're not going to turn it over to them like this.
To be honest, I would love to get you a Tuesday, Wednesday, Thursday. Yeah, just do that. Okay, we'll see how we do the first couple of weeks. And then
What is this Tuesday, Wednesday, Thursday? What the hell is this? What kind of treatment schedule is this?
we'll break it all from there.
See, you gave up. You gave up on Monday. That's why you said Tuesday. You didn't fight for Monday. You didn't overcome the obstacles for Monday. You didn't challenge them. You gave up.
Like I said again, on that 12 Tuesday, we're going to reevaluate more. Okay, that's the beauty of the test. Okay, where we're at. Okay.
You forgot. You forgot how ingrained it is in people, how much time they think it takes to see a doctor. It's unbelievably ingrained. You got to fight like a son of a bitch.
All right, I'll give this to Mason. I'll see you next Thursday, right? Okay, I'll see you. I won't see you on Monday, right? So I'll see you again Tuesday. Okay. Here's what I want you to do while I'm not seeing you every night. I still want you to ice again because you're in this phase. And then I don't think I did it with you today, but
Now, I don't know. I mean, they should be getting treated.
you've done the push-ups, down. So when you come in, I'm getting motion in your spine, right? Part of getting in this phase and even out of this phase is keeping the motion that I'm getting. So do that one exercise, the push-ups with the hip down.
Huge mistake. You just made another huge patient mistake. Not a clinical mistake, a huge patient mistake. How many people like to exercise? You just created one negative feedback loop is what you just did. I never, ever told patients to exercise at home. You know why? What percentage of them go home and exercise when you tell them to? By the way, he's in pain. You think he wants to exercise? And he's going to go home and exercise? Why don't we get into the real world here? So guess what's going to happen next? He's going to come in and you're going to ask him if he exercised. Well, guess what the hell he's going to say? No. Guess how that's going to make him feel? You think he's going to feel good about telling you he didn't exercise? What do you think that's going to do to the relationship? Oh, and then let's do it again. Make sure you exercise. He comes in the next time. Hey, did you get a chance? No, I didn't get a chance to exercise. Guess how much he wants to face you the next time? He doesn't want to face you at all. And he fires your ass. You never tell somebody to exercise at home. If they're going to exercise, you have them do it in your office and you have it controlled and you bill for it. If they're going to exercise, they'll do it on their own. 9.9 out of 10 patients will never exercise and you're destroying the relationship. It has nothing to do with clinical. There's a lot of clinical things we can do that make sense. That will be total violation of human nature. This is in total violation of human nature is what you're doing right now. It has nothing to do with being clinically appropriate.
Up and down for about 2 sets of.
Matter of fact, I'll tell you the truth. Every now and then patients would ask me, do I need to exercise? It just makes them feel good to ask that. Well, guess what? If they were going to exercise, they'll do it on their own without me. They'll say, do I need to exercise? And here's exactly what I said. Because I knew I'd help destroy the relationship. Instead, I wanted to save the relationship. And I said, I tell you what, when you have pain and inflammation and you still can't do everything fully, if you exercise, you're going to irritate it and it's going to cause more problems. So if you don't mind, can you just hold off on the exercise until we get back to moving fully with no pain or discomfort? Can we hold off? Guess how much they love my ass for saying that. I saved them from having to exercise.
Reps. Does that make sense? You're not holding it. It's mobilizing that spine, that area that I showed. Yeah. So I used to do that every night until I see you on Tuesday. Okay, guys? Yes, sir. All right, guys. Have a great day, and I'll see you on Monday, Larry, okay? Tuesday. I'm sorry, Tuesday.
Okay, I don't know why we're not adjusting them today. Maybe, I guess maybe you already did adjust them, hopefully, but usually, you know, they come in, get to report of findings, you adjust them, they go to the front. Now, again, I'm going to the front with these people. I'm not letting them walk up to the front right now until I got one hell of a good, solid practice with well-trained people. Because what can happen between right now and them going to the front? Them changing their mind. I'm going right to the front with them, and I'm gonna say whatever the name of my front desk person is. I'm gonna say, Mary, this is what whatever we agreed upon with the prepay. I'm telling them, Mary, so and so wants to do biweekly payments or whatever. If you could take care of that, that's what it would sound like. I'm not going to drop the ball between right now and going to the front desk, and you will lose patience, especially when you don't have black belt trained staff. Yeah. So if I'm going to rate this, because remember we rate our patient education in 5 categories. So we'll look at, okay, with the personality, 1. We'll look at tone, speed. We'll look at control. These are the factors that we'll look at. So personality, what little he talked, it sounds like he was more passive and she was more of the dominant personality. When she finally did talk, he sounded like he was kind of a passive phlegmatic. She sounded like a melancholy. So we just let a potential new patient walk out the door. She sounds like she's a little older. He sounds older. She sounds older. So she's female. She's a little older. What's the chances she's got arthritis, joint pain, an old injury, headaches, neck pain, something? Pretty damn high. Do we know anything about it? No. Why? Because we didn't even talk to her. We didn't even know she was in the room for 7 minutes. So personality, tone was fine. You got to be careful with older people in tone. You got to be careful. Tone was maybe a little high for these older people. You got to drop your tone down with older people. Speed was fine, but there was no engagement. Where was he as we were going through these topics? And where the hell was she, my God? Holy shit. Personality, tone, speed, control. Definitely controlled it. Good. And then content. How well did you cover the content? So I would say, what was the biggest thing out of this? Well, obviously it's money. Money, number 1, and time, number 2. The 2 biggest obstacles were not handled right. We're talking about letting them start payment 2 or 3 days from now, but not making a payment right now for some freaking office problem bullshit. Yeah, imagine Walmart saying, yeah, all our computers down are today. It's Friday. You can come back and pay for your stuff on Monday. Yeah, see how well that works. Time kills all deals. No, we don't let them wait to make a payment. They pay now. They start the payment now because it's over as soon as they make the payment. What do you think is going to happen in 20, 12, 24, 48, 72 hours with motivation? It's going to do nothing. You got nothing but hurting you. You got nothing but hurting you. There's no upside whatsoever at all. It's total downside for letting them wait till Monday. I got to find out what the hell this is about you and your office and payments. That's bullshit. Can't get payments. My God, if you can't accept payments seeing 120 visits a week, what the hell are you going to do at 150? What are you going to do at 200? Let nobody pay? Shit, you got a serious system problem if you can't collect payments at the time of the visit on a day 4. That's a big damn problem, not collecting money. Not collecting prepays when they agree to prepay, that's a big damn problem. That's not a minor. We just took the biggest obstacle, money, and we magnified the hell out of it. And then we gave away time. I mean, we did the 2 worst things you could do. Just push money back and time back. Those were the 2 big things. The other incidental things was the X-ray situation. And then we could have cleaned up the repair phase, like what I reported on, say the goal, therapeutic goal, give the time frame, and then the visits. That creates a lot of clarity of what you're doing and why you're doing it. And then the last thing was simplifying it by packaging it. There's 8 specific tests that tell us, and that's when we say the third party factor. There's 8 specific tests that not only tell us what the problem is, they tell us if you're getting better, worse, staying the same, or if you end up with a permanent problem to some degree. See, now it means something. 8, package it, and then itemize them out. 1, 2, this is yours, this is normal, comment on it, good, bad, or whatever. Number 2, this is normal, this is yours, good, bad, or whatever. Number 3, this is normal, this is yours, good, bad, whatever. It simplifies the hell out of it when you do that. Package it. Okay. All right, let me leave it like that. But if I had to grade this on a scale of 1 to 10, if it wasn't for the time or money thing, that would be like a 7, 6 or 7. I just want to clear up some of the miscommunication. But I tell you, if this is an associate in my office, we're going out to the barn. You just took the 2 biggest problems of why people don't stay and pay for care, money and time, and you magnified them. We're going out to the barn. This is not going to happen again in my damn office, period, Mr. Trainee. I'm just telling you how I would be treating my associate doctor relative to those topics. There's no way in hell this is ever going to happen again in my office. Here I'm doing everything I can, spending all this time and energy trying to minimize the obstacles of money or time, and you go ahead and magnify them. I'm mad as hell if you're an associate in my office, and it will not happen again. I will make such a scene that you will remember it the rest of your damn life. So you don't do that again. And it will be purposeful. The scene will be kind of like right now. It will be purposeful. All right, let me leave it like that. Greg, I got to ask you. I need to talk money for a second, Greg. I got to ask you a couple things. You initially offered 2 visits. You said 20% 2 visits, and then you went down to biweekly visits. Why did you do that? And what's the advantage for them? Well, first of all, we already said there's no advantage for them if you're giving them a 20% discount, whether it's a lot lower payment every 2 weeks or a lot higher payment in only 2 payments. So why would you do that? Can you hear me, Greg? Let me hit the, okay, you should be able to unmute there.
Yeah, I can hear you now.
Why would you do that?
So there's no benefit. You're right. There's no benefit to the terms of doing it in 2 payments. I've had patients more than one tell me that if they could do that. So that's just an option I've gone to. And
so you're not doing it for any reason. You're just reflects.
Right. It's just another option. Yeah. Just another term. Yeah.
Yeah, but can you understand why are we wasting our time dealing with it?
There's no discount, but I just feel like it's just another option, and I've had patients bring it up. Like I said, it's just another option for them to take care of it.
Now, Greg, let's say you're training associate doctors, right? Now, do you understand that do you understand associate doctors, when they start learning it, are very fragile? They don't have a lot of conviction, usually not a lot of confrontation either. And it's very easy to be rejected when somebody rejects money. Do you understand that?
Yeah.
So when you have an associate doctor try to go for too much money before their skill level, can you see how you're setting them up to fail?
Yeah.
Now, we don't know your prepay rate. We haven't done it lately. Do you know what it is? Have you done it lately, your statistics?
Yeah, I track it every week. I haven't done it over a 3-month period, so I don't know a good stat for you. But if I had to guess, it's 60 or 70%.
Okay, and I would say probably you're right based on what I'm seeing and how much your pay practice has gone up. So for you to try to go for more money with your skill level now, I would say yeah. But what advantage is there for how you did it?
Yeah, I admit there's no advantage to the patient.
So if you were going to do it, okay, how would you make it an advantage to the patient to pay for more up front as opposed to less over time? What would you do? What do most people do? How does that work?
You could give a better percentage off.
Right. You go ahead and give them a bigger discount.
Right.
So you might go, like when you're first doing it, you might give them a 30% for the full 2 payments, and then eventually 30% for 1 payment. And then if they don't, it's 20% for every 2 weeks. And then down the road, you could say, give them 20% for 2 weeks, 2 payments, or 1 full payment, and then a 10% discount for every 2 weeks. But can you see it? It absolutely makes no sense whatsoever to give them 3 different options, and there's no benefit to take the prepay, the higher payment.
Yeah, I get what you're saying. Yeah.
It doesn't make any sense at all. Okay. So remember, we don't do shit that doesn't make sense. And we don't do stuff reactively. We do it based on business principles and human nature. Now, I've got to get to how the hell come and you said our office can't accept payments now, and we start payments on Monday. What the hell is that about?
Well, I didn't word it. We can't take payments that way. And when we started, we would take payment on day 4. But where I was thinking is, so today's Thursday. So if I take a payment on Thursday, basically, usually I take payment on Mondays because it just keeps it all organized. We start on Monday, and I do have them sign. They put their card down. They sign a contract that they're signing up for this care. So they are committing, but, I was having my office staff run it right then and there, and I get that, exchange money for care, finalization. I get that. But for me, I guess if I take payment today, it's Thursday, right? The 18th. So then I just take it every other Thursday. I just thought we would group all of them into one because I am getting busier and it'd just be better organized, better organized and be better for patients.
You think it's better to increase the amount in 1 or 2 days than do a little bit every day?
I'm sorry, say it again. You're asking me what?
As the business grows, it's going to take more time to process the visits in one particular day. Can you see that?
Right.
And you're telling me you think that's better than doing a little bit every day?
Okay, I got you.
Increase their workload in one particular day. Let's start overwhelming them more and more on one particular day instead of keeping it small a little bit every day. You're telling me that makes sense?
Yeah. Okay, well.
And I didn't even consider, I'm not even considering the human nature part of this yet. You're right, they did sign it and you got the credit card. That does help. But damn it, we want the pay. And what's the other reason we want the patient, the payment now, because we want the damn commitment now.
Yeah, I get that. Yeah.
Now, what's the other reason you want to be billing every day? You want to be doing those payments every damn day as much as you can. Why? It's called cash flow. So the way you're structuring it, you're going to structure it where there's like one day where it gets to be overwhelming. They got to do a whole lot in one day.
Okay.
No, every day they go through and do 2 or 3 or 1 or 2, and as it gets bigger, 2, 3 or 4 every day. That's called cash flow, and it's a little bit every day at a designated time instead of it getting overwhelming. So now when she has to spend 1 or 2 hours of doing it, what happens with her position during that 1 or 2 hours?
Yeah, they can't do anything else. Yeah.
You see how you're screwing things up?
Yeah.
I mean, there's nothing positive about what you did. Nothing. And the worst part is the patient. Not the first, it isn't me. That's not the first part I care about. The first part is the patient not committing because they're not paying. And you flat out told them they don't have to commit. When you told them you don't have to pay, it's like telling them you don't have to commit till Monday. That's exactly what you did, even though you have a signature. They can come in Monday and go, I changed my mind. You know how many, Greg, you know how many prepays I refunded in all the years I practiced? How many people wanted their prepays back?
No.
Less than 7. And I don't remember any of them wanting it back because of nefarious reasons. The most of the time they wanted it back is because they moved, they weren't going to be able to make it in. It wasn't because they didn't agree with how the 3 phases of healing in their problem, and they lost trust in that. It was never because of that. It was usually because they couldn't make it in. They had to work more. They had to move. It was like unforeseen circumstances relative to them, not that they didn't believe in the 3 phases of healing and their problem and how it all worked. Well, what's my point in telling you that? When people prepay for stuff, it goes to the back of their mind. After you pay for something and you prepay, it goes to the back of your mind. It's over. Well, guess where it's at? It's still in this guy's mind. In the front of his mind. He's still got till Monday. What does time do to all deals? Does time increase motivation?
No.
You weren't thinking right on that one, man. You were not looking at this thing. The very first perspective you should have been thinking about. And I tell you, even if it's disruptive to my staff, I will still have it disruptive to my staff to get his damn money because I don't want him to change his damn mind. That's the single most important part, is him and the commitment, not you and your staff and your procedures. Because it's not about you and your staff and procedures. It's about the patient and them paying. Nothing happens without that. Nothing. That is the number one priority, period. And then we make it all happen and clear it out on the backside. But we are not going to violate the basic human principles of time and money. That's what still amazes me every now and then, is as sharp as Walmart is, or some of these stores with their systems. Every now and then there'll be a product come up to the front without a price on it, and they have to shut down the line to go find out what that. I'm like, are you kidding me? You don't have a system in place yet. I mean, to totally shut down the cash flow, the incoming cash. That's like, you never, ever do that. And then you put your systems in place to make it happen. Hire more accountants, create more labor, more space, more whatever. But you get the damn payments. Because nothing else works when you don't get the payments. So, but you understand, even though when you did get their signature and they committed, that was a degree of commitment. But when you said they don't have to pay till Monday, You understand? You still allowed time for them to change their mind?
Yeah, I see. I see what you're saying about them exchanging money at the time they commit to the care. Yeah.
And then I'll tell you the last thing. What's the biggest concern I have out of all of this?
What?
A way of thinking. Can you see it or not see it? Because if you can't see it, guess what else you'll do? Guess what other decisions you'll do? That's the single most important factor out of this. And you see how, by them not committing to pay and make the payment, you help to increase time, and time kills all deals. Now, granted, it's not a high percentage, but guess what? If you think that's okay now, guess what you'll do again? And then you'll do it again. And then you'll do it again. And then you'll modify it and do it somewhere else, and you'll do it again. And now you got a big problem. It's a way of thinking. That's the biggest issue. What was the deal with the treatment? Did you treat him before this report of finding?
Yeah, I did.
Okay. Is there a reason you treated? Is there a reason you treated them?
Well, that kind of, the reason I treat before I go over their, day 4 is because right when they agree with me in the room, I take them right up front and they schedule out and I do everything you say. You know what I mean? Because my thinking is it can bring up time again. If you have them commit and then there's a time lapse in between committing and treatment, you know what I mean?
Well,
So I've been treating.
I find that such a dichotomy that you're worried about the time they commit to the time they do front desk, but you don't worry about Thursday, Friday, Saturday, or Sunday, and you let them pay on Monday. I find that a dichotomy.
Yeah, it's kind of a contradiction. I get it. But that's why I've been treating them before I do the day 4 report of findings.
And then you let them walk up to the front by themselves.
No, I go up there with them.
Okay, because based on what I heard, it sounded like you were letting them go by themselves.
No, I go up there with them, and I'm talking to everybody, but it's like I'm talking to my front desk. I say, okay, Mr.
Okay,
Woodson.
I'm with you. Next one. What the hell is the deal with not talking to his wife?
All right. Well, the day she came in on day 1 and day 2, she did not come in on day 3. I actually told him to bring his wife on day 4. He did. And again, I don't think it's translated through the recording well. I had good rapport with them. I agree. I need to get them to verbally say something, but they were nodding their heads. They were with me.
We didn't hear from her for 6 to 7 minutes into the interaction.
Yeah, and she's kind of a quiet person.
What?
But I get the way you worded it when you were especially going over the test. That's much better. Yeah.
No, I'm talking about her. We did not.
Yeah,
I
but
did not even know she was in the room until
I know, but yeah, but the way you worded the test, you talked to her about it and him about it. Yeah.
You didn't say her name. You didn't. There was no distinction that she was in the damn room.
Okay, but I'm not some cold jerk. I am going in there, Dr. Paul, before I started the recording. I said, hi, Stacy, hi, Larry, and then I treated him, remember? So it's not like I'm cold as hell. I've already, you know what I mean? Yeah. But I do need to get her verbally to talk.
I'm only talking about what I heard, not what I didn't hear. Only comment on what I heard. There was 7 minutes with no interaction with that, with which in all probability was the decision maker. And again, it's a thought process. It's a thought process. You can't let them sit there and say nothing. You can't cover one topic after the next and let them say nothing. Now, not only from the decision maker standpoint, But Greg, guess what's going to happen to the bonding and rapport when I come back around and go after her as a new patient when you don't say anything through the whole time versus me engaging her the whole time? Guess where her defenses and her resistance are going to be when I come back around to go after her?
Yeah, it would be better if I talked to her. Yeah, more. Yeah.
All these things matter, Greg. This is the difference between being an average and a black belt. Average and a black belt. You want your associate doctors to be average? Keep doing what you're doing. Do you understand the X-ray part? How you didn't get them to acknowledge the X-ray? You just told them everything about the X-ray.
Yeah, I get how you want me to do it. Yeah. Yeah.
Show the normal, emphasize the normal, shut the hell up. Show them their X-ray. And the next question out of your mouth should be, do you see the problem? Shut up. Read them. Look at them. They just say yes. What do you see? They see the problem. You're done. You go, do you see the problem? They go, and they actually tell you what the problem is. You're done. But you can't talk people into shit. Okay, so a lot of that was just, again, higher level communication. Just, again, we're talking about the different. Obviously, we're not talking about being bad to average. That was obviously you'll do fine the rest of your life in practice if you just did that, Greg. The question is, are you going to be okay training associate doctors with that? Are you okay if your associate doctor did everything you just did in that room? That's the question, Greg. All right. So let me, those are all the major topics that we're talking about. The biggest one, like I said, was time and money. I mean, everything is about need, time, and money, need, time, and money, need, time, and money, need, time, and everything. So when we mess up something about money, it's bigger than what you think it is. If we mess up something with time, it's way more important than what you think it is, because those are the two big issues. And we can't be average. We got to be a black belt. By the way, same with Tuesday. Did you see how you let them off on Tuesday and didn't challenge them? Or Monday and you let them go to Tuesday?
Yeah. I had been over. I did do the time policy with them. You heard me do that, right?
Yeah, but I'm talking about when he threw the obstacle in your face, you didn't challenge him with the time policies.
Right. Well, I believe he brought that up before that Monday. So yeah, I didn't challenge him. I just said,
And
I
then
knew his.
and then you should have gotten specifics. You should have said, what time do you go in? What time do you get off?
Yeah.
You just let it
Yeah.
go. You didn't challenge him at all. You think I want my associates not challenging patients on time? They won't be in my office, Greg. They will not be in my office. They let money go and time go, I'm firing them. Because the patient's going to fire you. All right. Anyway, that was a lot of detail. And really all the nitpicking that we're talking about is the difference between above average and a black belt. We're not talking about sucking versus being average. You did that the rest of your life. You have a good practice. You'll live a good life. Do you want to train associate doctors like that? I'm not. You think it's going to, by the way, you think it'll get better? You let the associate doctors do that? It'll just, time and money will just get worse. They'll let more and more go with the obstacles of time and money instead of nailing them down. All right, so that was a pretty good overview. One last question. Is there a reason that you did not engage the other person into the admit phase after you were all done?
Yeah, I'm just so focused on getting who's in front of me. It's not in my way right now.
Right.
Yeah. I was surprised, and I was glad she showed up.
Yeah, but that's exactly what I thought. And all I'm doing is trying to point this out. that you're still in a state of conscious competence. You're still thinking about what to do. And that's why you didn't even think about taking her into the admit phase. You don't know how easy of a patient she could have been. She could have been unbelievably easy, but we'll never know because you didn't go into the admit phase with her. She could have been cake. She could have been easy as hell. We don't know that. And it was definitely a prime prospect, an older woman. They pay more attention to their health care. They're willing to spend more time or money, and they got more joint and pain related problems. We had a huge new patient prospect sitting right there. And he would have even told on her. As soon as I get her in the mid phase, I'd have turned to him and said, John, is that right? That's typically when they go, yeah, I've been telling her to get it taken care of for months now. That's the kind of shit that happens. But that's black belt stuff. That's unconscious competence black belt stuff. I would have nailed the time. I'd have got his ass in on Monday. He'd have fucking paid today, and I'd have nailed her as a new patient. That's what I would have done. And that's what we train. You have to make the decision if you want to take it to that level or not.